we have honor to invite Professor David Weber to have a talk. Welcome, Professor David Weber.
Thank you very much. Thank you very much for asking me to provide this presentation. It's a great honor. Over the next half hour, I'm going to talk to you about why high-level disinfection is necessary for endocavity ultrasound probes, and then we'll have time for questions and answers. As you can see in front of you is a diagram of a typical endocavity ultrasound probe. This is a probe that would be used in the vagina or rectum. We also do ultrasound in the esophagus for cardiac ultrasound. The part that enters the cavity requires high-level disinfection, or HLD, and it certainly would be contaminated by any organisms that might be present in the vagina, rectum, or esophagus. And even if you use a probe cover, as we'll talk about, there still can be underlying contamination. Now, in terms of the handles, if someone touches, obviously, the mucous membrane or the lower part of the probe, there can also be contamination higher up in the probe. Now, given the prevalence of current infections, diseases, we certainly need to be very concerned about ultrasound probes transmitting infection from patient to patient. Some of the major concerns would be Candida auris, a multi-drug resistant pathogen, which when it leads to infection has a high mortality, highly transmissible, and a growing problem worldwide. Human papillomaviruses can be classified into low risks for cancer and high risks, particularly types 16 and 18, high risks for causing cervical cancer, but they also cause vaginal and other cancers. And as they are non-envelope virus, and can certainly lead to both infection and then cancer. And we're always concerned about methicillin-resistant Staph aureus, MRSA, which can be present on any body surface or on mucous membranes. Now, ultrasound probes are widely used, particularly in obstetrics, gynecology, and with assisted reproductive technology, ART. Careful attention must be considered to the cross-contamination risk, that is, when contaminated by one patient, when the probe is then used on the next patient, associated with reusing endocavity ultrasound probes between patients. This is especially critical during the monitoring of ovarian response and follicular growth in vitro fertilization, emphasizing the need to mitigate the potential transmission of pathogens when applying any reusable medical device. So today's learning objectives are: what countries have implemented standards of practice for reprocessing endocavity probes through guidelines, standards, and accreditation requirements, for example, the Joint Commission International, or JCI. 2, learn what determines the minimum level of disinfection for reprocessing reusable endocavity probes. 3, what evidence-based research shows the risk of infection transmission associated with endocavity probe use. And finally, we will review guidelines for disinfection and sterilization of instruments in healthcare facilities. Just briefly, I am the Saunders Distinguished Professor of Medicine, Pediatrics, and Epidemiology at the University of North Carolina at Chapel Hill. This is on the East Coast of the United States. I also serve as a medical director of our Infection Prevention Department, Associate Chief Medical Officer for our 1,000-bed hospital, and I'm currently the Vice President for the Society for Healthcare Epidemiology of America. Well, here's just a list of guidelines locally and internationally to help users determine the appropriate disinfection level required for reusable devices. And clearly, I'm not going to have time to review each of these guidelines, but they're listed for you to look at them at your convenience. For Austro-Asian, particularly the APSIC, Asian Pacific Society of Infection Control, is very useful. But you can see here there are a number of other guidelines in the Asian Pacific region. In the United States, of course, the major set of guidelines comes from the Centers for Disease Control and Prevention. I was a co-author with Dr. Rutella of the most recent guideline, 2008, that is currently being revised, and I am a co-lead with Dr. Erica Shenoy on revising that. Of course, all probes and disinfection have to be approved by the U.S. Food and Drug Administration, the FDA, and there are other groups that have made recommendations for disinfection of probes. In terms of UK and Ireland, particularly the British Medical Ultrasound Society and Society and College of Radiographers and Health Facility Scotland, among others, have produced excellent guidelines. In Europe, there are a number of guidelines that have been produced in Sweden, Belgium, and France. And then finally, we have Canada, the CSA group, and the World Federation for Hospital Sterilization Sciences, and the World Federation for Ultrasound Medicine and Biology. And I should say, overwhelmingly, all of these guidelines follow the Spaulding classification that I will describe for you in detail in just a moment. So the Spaulding classification has been now used for decades, and it forms the basis for our guidelines for sterilization and disinfection. Basically, Dr. Spaulding believed the type of sterilization or disinfection that a reused medical device should undergo depends on the use of that device. Critical devices are devices that enter body cavities, such as surgical instruments. For these, all viable microorganisms must be destroyed, and they should be sterilized. Semi-critical devices are devices that touch non-intact skin or mucous membranes. For these, at a minimum, we do high-level disinfection, which destroys all viable microorganisms, except potentially for a small number of bacterial spores. And finally, we have non-critical devices. These would be devices that touch intact skin, such as a wheelchair, for instance, and we use low-level disinfectant on surfaces such as bed rails. And they should destroy the disinfection vegetative bacteria, except they may incompletely inactivate mycobacteria, fungi, and non-enveloped viruses. And you can see here, sterilization is used in an absolute sense. It destroys all viable organisms, including bacterial spores. High-level disinfection will then destroy in the order of more difficult to easy to kill mycobacteria, small non-lipid, non-envelope viruses, fungi, vegetative bacteria, and lipid envelope viruses. And low-level disinfection will inactivate or kill vegetative bacteria and lipid enveloped viruses. And we have this nice period of more resistant to less resistant for disinfectants. Here is another way of looking at the Spaulding classification. You can see here we have cross-infection risk, high, medium, and low. The Spaulding classification, again, for critical, probe enters, or any device that enters sterile tissue, or the bloodstream. Semi-critical, the probe or any device contacts non-intact skin or mucous membranes. And non-critical, a probe or a device would have contact with intact skin. And so we have the highest risk, of course, is with critical devices entering sterile tissue. Second, semi-critical devices touching mucous membranes. And the lowest risk is touching non-intact skin because the non-intact skin itself is an excellent barrier to viral, bacterial, and fungal infections. And you can see here for non-critical devices, we would use low-level disinfection. This would be a probe that touches intact skin, such as doing an ultrasound of a pregnant person to look at the status of the fetus, for instance, or placing a central line. Then we move down to semi-critical and critical. Semi-critical devices should, at a minimum, be high-level disinfected. Critical probes ideally should be sterilized. Some of the probes that are used cannot withstand either high-level disinfection, meaning sterilization using steam, and they don't have a validated method for low-level disinfection using gases or other means. In those cases, they should be at a minimum high-level disinfected and placed inside a sterile cover if placed into a sterile field to prevent contamination. But ideally, if they're entering sterile body tissues, such as a surgical site, they would be sterilized between uses. Well, let's focus now on guidelines for high-level disinfection of endocavity probes classified as semi-critical. Well, there are three critical steps. The first is thorough cleaning after each use. I should say for both sterilization and high-level disinfection, cleaning must always precede either of those processes, either sterilization or high-level disinfection. Cleaning is the physical removal of dirt, grime, blood, bacteria, and other things. It's a necessary step because if you have substantial amounts of protein, blood, or other materials on any device, it impairs particularly low-level sterilization and high-level disinfection. After appropriate cleaning, we do high-level disinfection. And then for endocavity probes, we would use a single-use probe cover before the next patient exam. And then you can see here's how each of those would work. And you notice that for intact skin, we don't need transducer probe covers, and they are low-level disinfected. But for non-intact skin, or for intracavity use, or for amniocentesis, then we would use a transducer cover and use high-level disinfection. For intraoperative, we would ideally use sterilization, but at minimum, we would use a sterile transducer cover and high-level disinfection. This is the Emmentaler cheese model, also been called the Swiss cheese model, for proper use and prevention of any disease. In order to get infection, all the holes have to line up. And here we're talking about HPV, human papillomavirus, and non-envelope virus, which is quite difficult to inactivate with many disinfection methods. So first of all, cleaning will remove about 2 logs of virus or other bacteria. Disinfection then would remove about 5 logs, and the probe cover would prevent contamination roughly of about 2 logs. Therefore, the total protective effect, we would add all 3 together, and you would see you're at 10 to the 9th reduction in organisms, which would be safe for preventing transmission of HPV from a patient to patient. So again, here is some data on the 3 steps to reduce contamination of HPV. UVC radiation is an effective disinfectant method to inactivate human papillomavirus. Of course, UVC, particularly at 254 nanometers, is the most microbiocidal wavelength for UV, and that's why UVC is the preferred type or wavelength for UV irradiation. And you can see here both for HPV 16 and HPV 18, which are the major HPV types that cause cancer, you're getting inactivation of 10 to the 4th or 10 to the 5th of organisms. And in a carrier test, the automated antigermics S1 and Hypernova Cronus devices showed excellent efficacy of both HPV 16 and HPV 18, whereas in some studies, orthoaldehyde, OPA, has showed minimal efficacy. These results suggest that healthcare facilities using endocavity ultrasound probes need to strongly consider disinfection methods that are effective against HPV. Well, again, we're going to talk about the 3 steps to reduce contamination risk. Zero logs gives you, starting with 1 million organisms, a 0% reduction. Just cleaning reduces it 99%. High-level disinfection, and then is adding 4 more logs. So now you've gone from 1 million down to just 99.9999% removal. But then, adding the probe cover plus potential as high as 10 to the 5th reduction, you can see here, even if you started out with 1 million human papillomavirus viruses, you would end up with 0. Unfortunately, a low-level disinfection, even if you use a commercial cover or a condom cover, is inadequate in activating these large numbers of HPV, meaning low-level disinfection plus commercial cover or condom cover may lead residual viruses being present and could lead to transmission if a probe is used on a patient who's infected and transmitting it to the next patient. Of course, that would not be immediately obvious that the patient had HPV. Only years later, when they developed cancer, would one know that potentially that there had been a failure and transmission from a reused medical device. On the other hand, when you add UVC, high-level disinfection, plus a condom cover or a commercial cover, again, you're down at 99.999999%, or a combination of somewhere between 6.6 and 9 logs reduction, and making the probe safe to be reused between patients, despite the possible presence of HPV, which is widely present in many persons, both in women in the vagina and in men in the rectum. Again, we have here our cheese model, Emmentaler cheese model, and you can see here for HPV there, if we're using low-level disinfection, a 10 to the 2 reduction in cleaning. Low-level disinfection will not inactivate a non-envelope virus such as HPV. So we're really relying on cleaning plus the probe cover, and we'll talk more about failures in the probe cover in a minute, so that you're likely to still have viable virus capable of transmitting disease from patient to patient. On the other hand, with disinfection such as UVC, you're getting a 2 log reduction plus a 5 to 7 log reduction plus another 2 log reduction. So we're talking about 9 to plus logs of reduction and complete elimination of HPV, making it safe to be reused on the next patient. Now, again, we'll go back to why high-level disinfection of endocavity ultrasound probes is necessary with our picture. Now, let's talk about the issues with probe covers and condoms. Many studies have shown failures of these. 13% of covers have tears even before you use them, post-transvaginal ultrasound examinations. Before disinfection in a study, roughly 34% of transvaginal probes had prevalence of bacterial contamination after the probe sheath was removed, either through a tear or a rip in the sheath, or as you remove the sheath, you're actually spreading the bacteria or viruses that are on the outside of the probe cover to the probe itself. 80% of probe handles have residual pathogens, including MRSA. Another study showed transducer cables were contaminated. A meta-analysis found procedures using low-level disinfection wipes, contamination remained up to 13% for pathogenic bacteria and 1% for pathogenic viruses, either because the whole surface was not adequately wiped and it's difficult to know what you've wiped and make sure you've wiped every single surface, or because the bacteria or the viruses were inadequately inactivated by a low-level disinfectant. Research shows that probe contaminated by probe cover and low-level disinfection. Many different studies. Study from Hong Kong, 7.5% after probe cover and low-level disinfection were HPV positive. 2 studies in France, between 3 and 4% contamination. Spain, 6%. France, 15%. So you can see that finding HPV positive probes after use is in fact quite common, and these would certainly be capable of transmitting infection from patient to patient. The study highlights that low-level disinfection is insufficient. A retrospective study revealed an increase in infection risk in the 30 days following transvaginal ultrasound. These patients were found to be at a 41% greater risk and a 26% greater risk of needing an antibiotic prescription in the 30 days following transvaginal ultrasound. So again, here we're looking at immediate infection as opposed to HPV later on causing cancer, but good evidence that low-level disinfection is inadequate, putting patients at risk for acquiring pathogens that the previous person that the probe was used on acquiring. Now, infection risks of low-level disinfection of endocavity probes. This was a computer model, and I was a co-author of this study. The goal was to assess risk for transmission of infection via endorectal or vaginal ultrasound probes using probe covers and low-level disinfection in France. It was a stochastic Monte Carlo simulation The results per year is that if France had used low-level disinfection for all endocavity probe use, there'd be 40 new cases of HIV, and for other viral diseases such as HPV, somewhere between 1,600 and 15,000. The conclusion was to adhere to many guidelines, including those from the U.S. Centers for Disease Control and Prevention, i.e. high-level disinfection of all endocavity probes. And you can see here the actual pathogens that are transmitted, particularly concerned for HSV2. And of course, for HPV, with depending on the model, 8,000 to 14,000 infections, but other viruses such as CMV and other bacteria such as Chlamydia trachomatis transmitted between patients. So again, an enormous burden on the population in a country the size of France. APSIC, or the Asian Pacific Society for Infection Control Guideline for Disinfection and Sterilization of Instruments in Healthcare Facilities, was revised by an appointed work group of comprising experts in just 2018, not too long ago. It aimed to highlight practical recommendations in a concise format designed to assist healthcare facilities in the Asian Pacific region in achieving high standards in sterilization and disinfection. What did they say? Critical medical and surgical devices that enter normal sterile tissue or vascular system must be sterilized. We've already mentioned that. Steam sterilized is the preferred method since it's the most robust method. And really, if you reach time and temperature for an appropriate duration, there's never been a failure of steam sterilization. And so it is the best method to use. And one would only use low temperature sterilization, gases or liquids, if the device would be damaged by steam. They note in the guideline that high-level disinfection is required for all semi-critical patient care items. That would include all endocavity ultrasound probes, and non-critical patient care items are disinfected when visibly soiled and on a regular basis, such as surfaces in hospital rooms. They go on to say policies and procedures must be established to ensure that the disinfection and sterilization processes follow the principles of guidelines as set out by APSIC, but also by the Centers for Disease Control, the World Health Organization, or the country's Ministry of Health. Completed policies and procedures should be reviewed by the Infection Prevention and Control Committee, must be readily accessible to staff doing the reprocessing, and those staff must be adequately trained in the proper use and adherence to those policies there. And there should be a review of the policies and procedures, as well as training of the staff, at least annually. Well, there are many guidelines here. Here's the Centers for Disease Control guideline. You can see I was a co-author of that with Dr. Rutella. Here's the APSIC guideline on the left, and we have other standards in Australia, New Zealand, and America National Standard, and then we have international standards as well, and they're all congruent in recommending that we follow the Spalding classification for proper sterilization and disinfection of reused medical devices. And here's our typical endocavity probe. And probes are classified clearly as reusable medical devices. We don't use single-use disposable probes. They need always to be disinfected between use. And the level of disinfection required depends on cross-infection risk. So those that touch mucous membranes or non-intact skin require high-level disinfection. Those that touch intact skin require low-level disinfection. Here is the guidelines from the Joint Commission of International Accreditation Standards for Hospitals, and it reinforces prevention and control. And this is the most recent guideline. Again, I encourage you to read that guideline. What does the guideline say? It explicitly says intent of PCI 6, procedures that involve contact with medical surgical equipment, devices, and supplies can be a major source for introducing pathogens that lead to infection. Failure to properly clean, again, cleaning always precedes high-level disinfection or sterilization, which is next, and improper use of storage not only poses risk to patients, but carries a risk for person-to-person transmission of infections. So particularly things like sexually transmitted diseases, C. auris, MRSA, VRE, and HPV, and herpes are all things that could easily be transmitted if we fail to do proper cleaning and disinfection and use endocavity ultrasound probes without proper cleaning and disinfection. And then they talk about the measurable elements. Hospitals should follow professional guidelines there and manufacturer guidelines for low and high level disinfection based on the type of device and equipment and how it is being used. Staff processing these devices should be oriented, trained in, and have demonstrated competency in cleaning, disinfection, and sterilization, and they must receive proper supervision. At my hospital, they have to take a multi-hour class when they first start. They get retrained, and they have demonstrations of competency each year. Methods for medical cleaning, disinfection, and sterilization are coordinated uniformly around the hospital by the infection prevention department, and clean and sterile supplies must be stored properly. Further, hospitals should reduce the risk of infection associated with medical surgical equipment and devices by ensuring, again, adequate cleaning, sterilization, and storage. And again, as with all of these other guidelines, they recommend that hospitals use the Spalding classification, named for Earl H. Spalding, to determine the appropriate level of sterilization disinfection for each medical device. Now, what to consider in selecting a high-level disinfection: 4 key considerations. First, workflow. Meet the clinical workflow requirements. The medical staff needs to consider turnaround time between patients. You certainly want to have adequate time to appropriately and efficiently disinfect the object. Traceability. Records of high-level disinfection must be kept by following standards and guidelines to ensure a system of traceability is in place to enable recall procedures to be followed in case of a decontamination failure. And this is a requirement in the United States and much of the world. Automation provides further benefits of a manual disinfection that includes reproducibility and consistent disinfectant processes between operators, reducing staff error and no exposure to chemical fumes. And then validation. You want to use an automated verified system that monitors critical parameters in real time to ensure high-level disinfection, such as for steam, appropriate time and temperature, for UV, appropriate energy that's administered. And the devices we've talked about all do that. They would not be approved, certainly by the Food and Drug Administration in the US and other countries similar to that, unless they did. So again, why high-level disinfection of endocavity ultrasound probes is necessary. Healthcare facilities that follow evidence-based guidelines for the disinfection of ultrasound probes enable physicians to perform ultrasound probes that boost patient safety, reducing probe cross-infection risks, reduces healthcare-associated infections, and up to 70% of HAIs are preventable using existing prevention practices. Actually, for transmission from probes, if you follow the correct procedures, they'd reduce 100% of transmissions. And transmission occurs due to inadequate cleaning, improper selection use of a disinfecting agent or method, and failure to follow recommended cleaning and disinfection procedures. Everything we do in medicine and in healthcare, prevention is always better than treatment or trying to cure a patient. So prevention in life is always better than dealing with the consequences. So in conclusion, the evidence-based research is a major driver in changing clinical practice, establishing new guidelines, and clinics adopting new technologies such as UVC high-level disinfection. Published research papers show ultrasound probes are a potential source of infectious transmission, posing a new challenge for infection prevention. Not all research is of sufficient quality to inform clinical decision-making. Therefore, you need to critically assess the evidence before you use it, i.e. comparing low-level disinfection practices to high-level disinfection processes and reprocessing ultrasound probes. The 3 major aspects of evidence you need to critically evaluate: validity, can you trust it? At minimum, a 4-log reduction. Impact, are the results clinically important? And applicability, can you safely and appropriately apply it to your patients? So thank you very much for listening to this talk on why high-level disinfection is necessary for endocavity ultrasound probes. And I'm happy over the next 10 minutes or so to answer any of your questions. Thank you again.
Now open questions for audience. Is there any question to ask Professor David Weber? The Professor, you mentioned UVC high-level disinfection. What kind of this disinfection? And do you do? How do you do the medical device surveillance or monitoring about a lot of medical devices? Thank you.
Thank you very much. So ultraviolet light has been widely used in medicine for years in many different venues. Most commonly, it's been used for large ultraviolet light machines for terminal room disinfection to be a supplement to standard cleaning. And it's widely used in the US, Europe, and many other places because studies have repeatedly showed that environmental service workers don't touch every surface with a chemical, leading oftentimes in 30 to 50% of the time continued pathogens in the room. It's been used for food surfaces for decades, used in ventilation systems for purifying the air, and more recently used in medical devices such as UVC chambers that we mentioned for high-level disinfection of probes. It's quite efficient because ultraviolet light falls off in terms of energy. It's a square of distance. So for disinfecting a room, you need very large bulbs and or long-term exposures. But when you put it into a chamber and the bulbs are just mere centimeters or less away, you can get very rapid disinfection of organisms. And while similar to chemicals, certain organisms are more resistant, such as spore formers and non-envelope viruses. At a microbiocidal wavelength of UVC, you get very rapid destruction of DNA, RNA, protein coats, inactivating the organism. Obviously, for steam, the key parameters are time and temperature. For ultraviolet light, the key parameter is the amount of energy distributed. And the device that we discussed here, the Kronos device, does in fact monitor how much energy is delivered to the probe surface. And with lights on the machine and other warnings that if a bulb, for instance, is not working, a warning would appear that inadequate amounts of energy have been delivered, and that goes on continuously and allows a readout to making of validation that you've achieved high-level disinfection. For chemicals, the key parameters are concentration of the chemical, which is chemical dependent, time of exposure to the chemical, and duration. But it is critically important that the chemical be able to touch every single surface to be effective. That's one of the advantages of steam, is that it penetrates penetrates devices quite well. But for instance, if you had a duodenoscope and it was had protein material in the lumen, and the chemical didn't reach the the whole surface of the lumen, then it would not work. The Kronos device is designed specifically with location of bulbs and mirrors, such that adequate energy is delivered to every single exterior surface.
请问在场的有没有任何问题想要请教 Professor David Weber? Professor, we have one question asked by Chairman Professor Chen.
Professor Weber, I'm President of Infection Control Society of Taiwan. On behalf of the society, we really appreciate your wonderful talk. As an infection control personnel, during your talk, you demonstrate the advance on practice, incorporate new technology. As you mentioned, the endocavity ultrasound probe, it creates the risk of cross-transmission, but not aware by the clinician who perform this procedure. You highlight this risk and provide the solution for us. And you also emphasize it is very feasible as we infection control personnel try to persuade our colleague, gynecology or urology and others to increase the level of disinfection, but they always complain about the time, always complain about how can they keep on the high turnaround time in order to serve more patients. But during your presentation, you repeatedly demonstrate how to incorporate this new UV and other disinfection process to increase the benefit or disinfection, but also in a reasonable turnaround time. So this is very important. We learn from your presentation. So thank you again on behalf of the whole society.
Thank you very much. And actually, come January, I will be president-elect of the U.S. Society for Healthcare Epidemiology of America. And I would love to see our two societies being able to work more closely together. Thank you for inviting me.